Hello, good morning. Thanks for the introduction. Thanks for the opportunity to be here. I've been slated for 70 minutes and I'm not going to take that long. And it's especially hard because you now have a visual of lunch sitting right over there. So I hate to be the one to be in between sitting and eating, but hopefully it'll be of value. And I would love for this to be interactive. In other words, if you feel like I have said something you want to ask a question about, or add a comment about, please don't hesitate. So I'll go ahead and get started. So as you heard, I'm a neurologist and a palliative care physician. And one of the tenets, you can't really see it well there, but it says words matter. One of the tenets of palliative care is a reminder to us that words matter. And the word palliative itself, a lot of people haven't heard of it, or if they have, it conjures up all sorts of ideas. How many people in the room have heard of palliative care? It's a nice, most people. And could you just shout out some words that palliative care makes you think of, or what you associate with it? Anything, just shout it out. I'm so curious.
Love.
Love? Thank you. You're biased, but I appreciate it. I had the pleasure previously of working with Megan in clinics. So I'm lucky for that. So love. Sorry?
Comfort.
Comfort. Love that too. Thank you.
Less stress.
Less stress. This is a self-selected audience. I'm starting to realize. Any other words though when people hear palliative? Is it a good word, a scary word, neutral? But all right, so palliative care sometimes conjures up some negative thoughts for some people. Some people get scared by the word and say, you know what, that word has a lot of charge to it. You really need to change it. And sometimes, as you heard in my introduction, you heard that I trained in hospice and palliative medicine. And a lot of times the word hospice is associated with palliative. And I'm not going to spend time talking about what palliative isn't, but I will say that palliative care and hospice are separate things. And I'm going to focus on palliative care. So what does it really mean? Conjures up a lot of different words. I heard love, comfort, and so on. I appreciate that. The word palliative, I love the word and what it really means. It comes from a word that actually means to cloak. And I love this visual because the idea of a cloak is like another layer of support, palliare. And some people say, well, it's got this negative connotation, the word palliative. Why don't you just call it something like supportive care? And I'm a purist because I know the meaning of this word, and now you do too. I prefer to use the word palliative rather than supportive care. I think it's the organist, right? Okay. All right, well, palliative care is showing up more and more in Huntington's disease. A lot of times people associate it with cancer. That's another thing I hear a lot about. Palliative care, that's for cancer patients, right? Well, actually, sure, it's for cancer patients. It's for anyone living with a life-limiting or a serious illness at any stage. So it is coming up more and more often in Huntington's disease. In fact, I'll be at the Huntington Study Group meeting, the HSG meeting in a couple of weeks to talk about palliative care there as well. So there are plenty of opportunities more and more to see palliative care showing up in the world of HD. But how else can we define it? Well, the head of palliative care at UCSF, Dr. Pantalot, describes it as a way to live as well as possible, as long as possible in the face of a serious illness. I like that as well, to distill it down. It gets a little confusing though, because people say, well, isn't that what all medicine is or supposed to be? And in fact, yeah, it is. Palliative care in a very general sense is an approach to care. It's part of basic patient care that all healthcare providers are providing, focused on good communication with the patient and the family, shared decision-making, making decisions as a team with the medical side, but also what's most important to the patient and family, as well as setting goals and focusing on symptoms. So palliative care is basic healthcare, or at least it should be. Specialty palliative care is for people that have gone and gotten extra training, and it's for more complex issues, which may or may not be covered by other services. For example, a palliative care team would be focusing on goals of care, advanced care planning, and potentially other complex symptoms. So that's what we're going to talk more about today. The idea is that a palliative care team, a specialty palliative care team, is coming alongside your main neurology or other medical teams to provide that additional layer of support to the patient and family. And I can't stress enough, it's at any stage. Some people mistakenly say, oh, palliative care, that's for later on in the course of an illness or of a condition like HD. In fact, it can be useful at the time of diagnosis. Why wouldn't we want another layer of support? We do want to be sensitive to not burden people by too many medical visits, because you could easily spend a lot of time seeing different doctors and teams and so on. So that's not what I'm suggesting, but at least meeting a palliative care team early on in the course of any serious illness or life-limiting illness can make sense, and hopefully I'll appeal that to you in a few slides. But it's definitely not high tech, it's high touch, right? There's nothing fancy about it. It's high touch. So in palliative care visits, specialty palliative care visits, we're focusing on complex symptoms. That could look like behavioral issues, sleep problems, constipation, mood problems, chorea, tremor, all those things, kind of adding on to what care is already being provided by a neurologist. We're focusing on coping and support, and we're focusing on future planning. If I could distill it down into 3 buckets, those would be the 3. Any stage. And ideally, palliative care is provided in a team, with the patient and family at the center, a medical provider, a physician or a physician assistant, a nurse practitioner, a nurse, a chaplain, and a social worker. And this is the ideal scenario. It doesn't mean that all the team members are going to be present in the visit with the patient and family. They can be asynchronous visits, but ideally, this is the sort of setup of a palliative care team. And the reason is because we recognize that living with a condition like HD is far more than just physical symptoms, right? A chaplain can be there to help with the spiritual side, which I'll get into in a few minutes. Social work, you've already heard about today, can be instrumental in a variety of ways, including resource support and counseling. So it's best provided by a team. Where can you find palliative care? There are a few different places that palliative care exists. One is in the community. Community-based palliative care is a resource often not known about. You don't know what you don't know, right? Palliative care can be provided by community-based programs. Sometimes and oftentimes they're associated with a hospice, but they're separate. They're under the same umbrella, but different. Can be provided in the hospital. If patients are admitted to the hospital, there are often palliative care teams working in the hospital in consultation. And then there are clinics, outpatient clinics, which is what we have at UC Health and Shoots, clinic-based palliative care. So you come in as you would to another medical visit into the clinic. So these are the 3 main places that you would find palliative care support. What are the tools of palliative care? So as you heard, I'm a neurologist, Dr. Kumar, Dr. Forbes, and so on. We're all neurologists with movement disorders training. So when we were in training, our tools were jiggling around in our white coat pocket, like the hammer, the reflex hammer, the tuning fork, the stethoscope. All these things were our tools. And that's what I relied on when I was strictly focused on neurology and movement disorders. But as I've shifted my practice to be focused on palliative care, my tools now become listening, but more than that, questions, trying to ask powerful questions. And this is what is kind of jiggling around in my brain rather than in my pocket. Instead of tools physically, the questions that I ask are the tools. And you'll see throughout the rest of this talk that powerful questions really underlie a big part of palliative care. So what are the interventions, so to speak, that we're providing when we have a palliative care visit? Well, the first I would say is the goals of care conversation, which is really an exploration rooted in the questions to try and get to know who the person is in front of us. Before seeing someone as a patient, we really want to see them as a person first. The other interventions, which I'll highlight, are we provide assistance with medical decision-making, with advanced care planning, and then support with coping. And I'll get into all of these. So what are goals of care? I used to think that goals of care simply meant, what does a patient want in terms of treatment? Somebody might say with HD, oh, I want to have my chorea focused on, I want to have less chorea. I want to walk better. I want to, something rooted in symptoms. But actually what I mean by goals of care in a palliative setting really is what matters most. What are the person's values, the person and their family? What really matters the most to them? And this is different than treatment goals or medical decision-making. This is dependent on what's going on at the time in their life. So it can change certainly over time. And as HD progresses, only the most important values are what continue to stay stable along the way. And so these are value-based goals of care. Could be anything from spending more time with family, being as independent as possible, going to a reunion, going to an event. These are what in life is most important and how can we help achieve that if possible. And so the way that we get at these kinds of questions, we don't just say, hey, what are your goals? What are your values? I think that's just too on the nose, and it's hard to actually have a conversation with those kinds of questions. And so we ask a variety of other questions, such as, what do I need to know about you as a person to give you the best care possible? It's broad, right? And that too can be hard. Sometimes people are like, well, this is a medical visit. I don't know what you want me to say. And I might say, well, have you always been from Colorado? Like sometimes that allows people to say, okay, well, let me tell you a little bit about my story. What's important about your story? That's another question that sometimes people respond well to. What are some of the things that make you you? What was life like before HD became obvious for you? What are you most proud of? What puts a smile on your face? How about you could ask someone to fill in the blank. If I could not do or be blank, it wouldn't be me anymore. Or what functions or characteristics are so important to you that you can't imagine living without them? Again, these are questions that are really provocative and allow us to try and get to know someone better outside of just what's in the medical record. We also are really keen to know who are the people that support you, what are you hoping for, what are you worried about? These are different sides of the same coin, hope and worry. And what's the hardest part of this? I think that's a particularly powerful question that gives us insight into the practical side of what life is like day to day. For people living with HD. So the goals of care conversation, again, is an exploration with a bunch of questions that we hope can really evoke a robust conversation so we can try to get to know someone. And if the person in front of us, the patient, the one with the diagnosis, is unable to answer these questions, then we turn to the family or whoever's with them to try and get a sense from them. So why are we doing that? Well, certainly it feels good to get to know our patient and who's in front of us outside of just the medical record. But we're trying to really extract their values, their hopes, their goals, who they are as a person, and their life story. All of that together helps us have a better comprehensive understanding. So then we can see what's possible medically and how do we match those things up, right? So when I say what's possible medically, that could look like home health placement, medication or clinical trials, procedures, surgeries, code status. These are all the medical side of things that when we're helping patients and families make medical decisions, we want to rely on what we've just learned from their values, their story, what's important to them, to be able to help guide them in making medical decisions. And then that becomes the treatment plan, the negotiation of goals of care and what's possible medically. So that's a goals of care conversation. What about assistance with medical decision-making? What do I mean by that? Well, informed medical decision-making is taking, what is most important to you and having all of the information about your illness or what's being presented as far as a procedure, a test, et cetera, and trying to make sense and navigate next steps. Trying to help you clarify your goals and ensure that that's clear to other medical teams. That's another key point here, because a lot of times people living with HD and other conditions are seeing a variety of different specialists, and it can be really hard to coordinate that care or communicate the same message. So we're trying to share what we've learned in these goals of care conversations with other medical teams in order to help people make informed decisions. And so naturally, living with a chronic illness means you're likely going to have to make difficult choices that affect your well-being. And some of those questions or choices can be simply, should I enroll in a clinical trial? I mean, for some people, that's a no-brainer. They're like, absolutely, I'm going to enroll in a clinical trial. I want to help push the field forward and so on. That's not the case for everyone. Some people think, well, I don't know, I don't want to be a lab rat or something like this, or I don't know what that means. That's a scary idea, and so on. And so we really try to be helpful for medical decision-making for this. And we use frameworks, for example, not just what are the risks and benefits of enrolling in a clinical trial, but what about the burden? I think it's important, and we often overlook the burden piece of participating in a trial or having some sort of treatment. What does the burden means? What does it really look like to participate in this? If your goal is to spend as much time with your family and be outside as much as possible, and you're thinking about a clinical trial that requires coming into the office, driving several hours, and having a test every week or every month, maybe that's not a good trade-off. Maybe that burden is too high. So really having discussions with people, making medical decisions rooted in risks, benefits, but also burdens. That's a framework we like to use. What about an elective surgery? A lot of our patients are being faced with, you should have this orthopedic surgery, or you should have this colonoscopy, right? That seems pretty basic. But if someone has advanced Huntington's disease, maybe a colonoscopy isn't the best plan. Maybe it is, but it's worth discussing, right? Because if someone has a colonoscopy and they go through the prep and they go through the sedation and everything, that could be really a setback for them, depending on how ill they are with HD or something else. Maybe, maybe not. And what if we find something? What if we find something abnormal on the colonoscopy? Some people say, well, yeah, I want to go and pursue it and get the next test. And if it's, God forbid, cancer, I want to get treatment. Other people say, I don't want to look for something because I'm not willing to go through chemotherapy or et cetera, because I'm already really sick or advanced in my HD, for example. So really having conversations about anything procedure-wise, from a colonoscopy to an elective surgery, we want to focus on best, worst, and most likely scenarios as another framework. So this is how palliative care teams can be helpful or want to be helpful when it comes to medical decision-making. Really getting to know someone, helping navigate and guide through medical decisions. What about advanced care planning? So advanced care planning is planning in advance for medical care, sort of thinking about the what ifs of the future. I used to think that it was called advanced care planning, and it is not advanced in any way. It's planning in advance. It's pretty basic, actually, not advanced at all. And so it's, again, planning for future medical wishes if you should ever be unable to make these decisions for yourself. Now, this applies to all of us, HD, non-HD, any diagnosis or lack thereof. This applies to all of us, caregivers and so forth. So this is, pay particular attention to this part. I can't say this enough. It allows all of us to have our voice heard, even if we can't speak for ourselves, if a medical decision has to be made. 70% of people lack capacity when they're at the end of life, when medical decisions may have to be made, right? If you don't have capacity and you can't speak for yourself or speak clearly enough, then who's going to make medical decisions for you? Are they going to do it in a way that's honoring you or making a decision that you would have made if you were able to? The fact that we know that 70% of all comers don't have the ability to make medical decisions at end of life, for example, means we really ought to write our decisions down when we can earlier in life. And it's more likely if we document them that they'll be honored, right, than if we didn't document them. And it really does lower the stress, the anxiety, depression, and provides higher satisfaction in the family members, knowing that the medical decision-making has been documented and that we've had these conversations and everyone's as clear as they can be about how to honor this person or how to make medical decisions for the what ifs if they got sicker in the future. So for a lot of people, this can be an elephant in the room, thinking, oh, we haven't done that yet, or, we'll do that later when the time is right. The time's always right. I guess the time could be wrong. The time could be wrong if we're in a crisis and we haven't had this discussion yet, medical crisis, and need to make a rash decision. That would be the worst time to make these kinds of decisions. So ideally, we're having these conversations when there's no crisis and people are able to speak up for themselves. And why wouldn't we do this, right? We prepare for all sorts of emergencies in our life. During the peak of the pandemic, we were stocking up on toilet paper and everything else. We have fire insurance, we have insurance, and so on. This is just another way to prepare for the what ifs of the future, is to document wishes. And so advanced care planning, very basically, is sharing your wishes, having the conversation, and documenting it. And it's associated, as I said before, with satisfaction, with less stress, and so on. But unfortunately, less than 10% of neurologists indicate or initiate these kinds of discussions at the time of diagnosis of a condition. I think there's a lot to talk about when somebody's first diagnosed with anything, certainly HD, right? There's plenty of things to talk about. What are we going to do next? What are our next steps? What are the treatment options of clinical trials? There's no room oftentimes for a discussion of like, hey, here's an opportunity to make sure you've got your medical power of attorney documented in your advanced directives. And neurologists maybe think, well, that's probably not our job. The primary care doctor is going to do that or did that, or we assume that they've done it. But in fact, neurologists have a great opportunity to have these conversations, if not at the time of diagnosis, anytime after that, just to check in about it. So it's basically just two elements, advanced care planning: medical power of attorney, which is thinking to yourself, who is the person I trust the most, who knows me the best, who could be my voice if I couldn't speak for myself to make medical decisions. That's the person that would channel your voice in those moments when they need to make medical decisions, and documenting it. So that's the first of the two pieces. The second is the living will, or the advanced directive. This is a document signed by the patient stating what type of interventions he or she would want in the event of a critical or terminal illness, or if their medical condition changed suddenly. That's it, those two elements. And you don't actually need an attorney to generate these, particularly in Colorado. And so I'd love to give you some homework. If you haven't already done either of these things, the medical power of attorney, as I said, doesn't require an attorney. It doesn't even require a witness or a notary or any money. You just go online here in Colorado, search medical durable power of attorney, or MDPOA, print it out, fill it out, you sign it and initial it, and indicate the names of the people you would want to be as your voice. That's it. It's very easy. Interestingly, in the state of Colorado, you might not realize this. This is an all interested parties state. What does that mean? That means if you land in the emergency department and you're altered in some way, fuzzy-headed, can't speak for yourself to make a medical decision, and you're by yourself, the medical team doesn't default to calling and asking your next of kin or your spouse to make medical decisions for you. Instead, we have to assemble all interested parties who would be interested in your care, have them make a consensus on who would be your voice to make medical decisions for you, and then that person can be the voice and make those decisions for you. So we have to have it documented, particularly in Colorado. Otherwise, we have to go down this rabbit hole of assembling anyone that could be interested in your welfare to have this kind of an all interested parties meeting. And having done this on the hospital side, it can be really tedious to assemble such a group or to get them all on the phone. So this is the simple way around that. The document that you can use as an advanced directive could be the 5 wishes document, for example. You can find this online as well. It really is a nice guide. I've done this with my family and I've done it for myself. It guides you into, any sort of boundaries you would want to have on your care, things that wouldn't be acceptable to you, for example. So it's one example of an advanced directive that you can consider, any of us can consider. And here's a handy website in our state, coloradocareplanning.org. Can be a really helpful resource. So that's the homework for all of us. And then lastly, when it comes to palliative care intervention, so to speak, the support piece, the support with coping, the support with the daily living with HD, both for the patient living with it as well as whoever's close to them. So when we're talking about a palliative care team, as I mentioned, ideally it's a team. We've got the neurologist or an advanced practice provider, a nurse, if we're lucky on the team, is, and I say lucky because there's a lot of turnover in healthcare these days, but nurses are very equipped to go through medications, talk about home safety, ask who your medical power of attorney is, and screen for any caregiver distress. Chaplains, I also like to call them spiritual care counselors, because I think, as I said before, words matter, and the word chaplain sometimes takes people aback, particularly people that don't identify with the religion or any sort of spirituality. So spiritual care counselor is more often what I like to say when I'm describing these folks. They're the people that tap into your spirit, and they ask questions like, how's your spirit? And I'll get into that more in a moment. And then social workers, I think, as I said before, and you've heard from Megan, wear a lot of different hats and have a lot of skills. But certainly some of the skills can be connecting people with resources in the community, screening for caregiver distress, advising on financial or insurance benefits, providing counseling and support, and so forth. So let's get more into the idea of what the chaplain is and the spiritual care piece when it comes to care. And why would you need spiritual care in a medical setting? That seems rather foreign to a lot of people. And, I think it's more common on the hospital side. When people are in the hospital, there are more chaplains around and you think, oh, here comes the chaplain, something's happening. You can associate chaplains with hospital side, but in the clinic side, in the outpatient side, chaplains can be equally, if not more helpful, because you can have a longitudinal or a long-term relationship with them. So the idea of the chaplain or the spiritual care counselor is to come alongside people who are often wrestling with the deepest questions of their reality related to purpose, sort of the why behind the what. Why is this happening to me? Goals, again, but in terms different than the goals of care that we talked about earlier, the chaplain's goals that they're focusing on are more things like, where do I want to be in my soul? Or how do I want to reconcile some relationships that are uneasy for me? They're talking about identity. Think about the change in identity that often happens when somebody is faced with a serious illness. Perhaps they were working and their identity was rooted in their career. And now, in the face of a serious illness, their identity has shifted and they're no longer working. These massive shifts sometimes occur in identity, or your identity within the family. Maybe you were the breadwinner and you're not anymore. The chaplains really like to get into deep discussions about people and their identity and help perhaps ease people into a new identity or to loosen the grip on the old identity that they so identified with. They talk about meaning. They talk about connection, either to people, to the universe, to God, to nature. And those are just a smattering of kind of broader topics that chaplains or spiritual care counselors address in medical settings. It can continue to be connected to someone who has, their religious background if they have one, but it really doesn't have to. Again, when somebody hears chaplain, they think, well, I'm not religious, is a common response that we hear when we're offering, would you like to meet with the spiritual care counselor? And we try to reassure people that, oh gosh, you don't have to be religious. They're not proselytizing. They're not here to even talk about religion. If you bring it up, they'll go there with you, but that's not the agenda. And they're going to talk about any core beliefs that you have or don't have, and explore them and see how can we help you find more sources of strength in the face of living with a chronic illness. So some examples of questions that they might face from patients or family members enduring a chronic illness. Why is this happening? Why? Right? That's a common question. Why is this happening? What does it all mean? How do I make sense of all this? Even in a case like Huntington's disease, where often it's a Huntington's family, right? Where the patient with HD has been familiar, oftentimes, not always, with Huntington's. Still, there's so much room to ask these questions. How do I feel about these changes in my life? What gives me comfort? What gives me hope? Do I have either of those things? What am I grateful for? What or who do I trust? Who is my beloved community? Who loves me and who is loved by me no matter what? Really taking stock of that are some of the questions that come up in these visits with spiritual counselors. What or who beyond myself do I believe is important in my life? Checking in with that can be another way to try to tap into sources of strength in the face of living with HD. What do I call good in my life? What do I call bad? I think in the world, we're quick to label things in sort of a black and white way. This is bad, this is good. And chaplains, once again, provide provocative questions to help people really question some of these core beliefs that might be getting in the way or adding to their suffering. So how about a case example? Let's say we've got a 65-year-old gentleman, GH, with newly diagnosed Huntington's. He's not religious, he's very clear, but he believes in God. And he's asking questions in the neurology visit like, why is God punishing me? What bad things have I done to deserve this? And as a neurologist, we don't have training in how to address these questions. So thankfully, I'm very lucky. I have 3 chaplains in our clinic. They're all part-time, so they're not all at the same time, but we have access to spiritual care. So this is, of course, a trigger for me to want to get some backup, get some help from one of our spiritual care counselors. And so because this person is clearly wrestling with guilt, questioning God's role in providence, the neurologist refers him to a chaplain. So the chaplain's role in this case, he joins him in his struggle, but also points a way beyond the struggle, inviting him into hope, purpose, but not forcefully, right? In a very gentle way, once again, with questions. So the chaplain asks, how do you think God wants you to live now that you have Huntington's disease? It's an interesting question. I'm sure there's no easy answer, but these are the sorts of questions or tools that the chaplain, the spiritual counselor, is going to try and use to address this existential suffering. What are some of the sources of strength you've leaned on or turned to in the past or have access to in the present? I think a lot of us don't realize that we have strength or just assume, oh, I don't know, I'm going to flounder here, I don't know what to do. But sometimes having a discussion with a chaplain offers you an opportunity to look back on other hard times in your life and think, oh, how did I get through that? Okay, I leaned on my family. I, had a writing practice. I did something, just tuning into what worked before can be helpful. And then the chaplain asks, are there any spiritual resources or practices you have turned to and found helpful? Things like prayer, reading, meditation, etc. So this is perhaps the start of the interaction with the chaplain, starting with some questions and then thinking about, okay, what tools now? Now what? So chaplains make use of a whole variety of different strategies and tools. Again, not necessarily rooted in religion. There are mental and spiritual practices, whether it's meditation, mindfulness, slow and deep breathing, progressive muscle relaxation, biofeedback, et cetera, et cetera. You might not think, oh, why a chaplain does all those things? Well, potentially. Chaplains are well-versed in a variety of skill sets to help people feel more grounded and provide them with more tools. And so there is a long list here. They can help guide people towards creative practices, therapeutic journaling, letter writing, gratitude journal, singing, etc. They can also encourage people, depending on how they're doing, to think about service activities, volunteering, considering a pilgrimage, vigils, marches, etc. So that's another area that chaplains might tap into. Relational practices, chaplains also talk about. They can, refer people for counseling or tap into a social worker for counseling, and talk about interpersonal dynamics. Some of them are also trained as family therapists, sometimes chaplains, and so they can be skillful in talking about dynamics in families. They can also suggest support groups. It doesn't just have to be a social worker, etc. They can offer suggestions about rituals, ceremonial practices. They can talk about creating a sacred space or going on a retreat. And then lastly, some body kinetic practices and activities. They can suggest, Tai Chi, Qigong. I mean, all I want to point out here is that there's a broad array of different suggestions and potentially skill sets that some spiritual care counselors have that can help additionally support patients and families in distress in the face of a serious illness. And these are all actually listed on our website. If you want to refer to this list again, it's just neuropalliative.org in a caregiver section. But anyway, all that to say, asking questions is important, but then what, right? Then we've got to come up with some next steps. And these are often the sort of areas that chaplains might draw on. So here are 2 quotes that I think are certainly very powerful. This is Viktor Frankl. I'm sure many of you know who he was, an Austrian psychiatrist and Holocaust survivor. He said, we cannot avoid suffering, but we can choose how to cope with it, find meaning in it, and move forward with renewed purpose. And I think that's the perspective a lot of our spiritual care counselors have in trying to help people not ignore the suffering, recognize it, name it, but also think about now what? Now, what do we do with it? How do we come up with some strategies to work around it or work with it? What about the topic of resilience? This comes up a lot. According to the American Psychological Association, resilience is the process of adapting well in the face of adversity trauma, tragedy, threats, or significant sources of stress, such as family and relationship problems, serious health problems, or workplace and financial stressors. It's kind of a broad definition, but a starting point to think about the topic of resilience. What is resilience? When you think about resilience, any thoughts that come to mind? Some people say it's the ability to bounce back. Like, you either have it or you don't. Other people say, well, resilience is the ability to remain flexible, like a rubber band under stress, or to bend like a tree branch in a storm. Any other thoughts on what resilience is or what it isn't? Well, it's not a characteristic trait that some people have or some people don't have, right? Which gives us all hope that we can dial up our resilience. Cultivating resilience is really a learned, ordinary process and something anyone can develop by adapting behaviors, thoughts, and actions. A lot of people think of resilience as a battery, which may be fed by physical, mental, spiritual, emotional sources. And when our batteries are low or empty, we don't have much energy or any at all to draw upon to manage our feelings, to problem solve, to make clear decisions, and to respond well in tough situations. So what is this? This is a common concept, right, of an empty vessel or an empty cup. And the idea, I know it's used a lot, but I still think it's powerful. The idea that an empty cup or an empty vessel has nothing to give. And the idea of being depleted as a person living with a chronic illness or as a caregiver comes up a lot. How do you fill that cup? And it's easier said than done, of course, right? I'm standing up here just throwing around ideas. But the goal is really to think about what matters most. How do we carve out time for it? And what's going to be most effective and helpful in helping people keep their cup somewhat or all the way filled as much as possible? And so when it comes to caregivers, there's a huge potential for care partner, caregiver distress in the face of living with Huntington's, being part of an HD family, and so forth. And a lot of people, even if they're familiar with Huntington's, can be very underprepared for this role. At the end of the day, there's really no handbook. Everyone's situation can be quite different and personalized. One case of Huntington's isn't necessarily just going to be like the next, right? Even in the same family. Roles are evolving, right? As a caregiver or as a loved one, watching your loved one have HD or something else that progresses over time, things are evolving, roles are evolving. There can be a high level of burden, certainly depression and increased mortality among caregivers, not unique to HD, amongst all caregivers in various medical situations. And caregiver burden is associated with many things, including spiritual well-being, health-related quality of life, caregiver anxiety, depression, and perceptions of their patient or their loved one's quality of life as well. It's very normal, right? I think we all know this, to have feelings of fear, anger, resentment, frustration, anxiety, grief, sadness, and guilt. And all of those things deplete the battery or deplete the cup, or however you want to think about it, are really depleting. And those emotions can happen in your face and be very obvious. And they can also happen behind the scenes in the background of our thoughts, draining our body and mind sometimes and affecting even your heart rate, your blood pressure, and so on. It can become physical. And what we really strive to do on the medical side is to try and prevent families and care partners from getting to sort of that frog in boiling water scenario where you think, how did we get here into this pot of boiling water? We really want to not let conditions boil to that if we can help it. So talking about advanced care planning, talking about goals of care, helping assist people with medical decision-making, drawing on resources from caregivers are all ways that we try to avoid getting to a state of crisis, all the while seeing the caregiver and trying to help connect them or help keep them connected to whatever supports we can help them with. Many of you may be familiar with the Caregiver's Creed. If not, I suggest looking it up because I think it's a really handy reminder of a variety of things. And I'll just read it. Don't expect you to be able to see that. But again, looking it up online can be a handy resource. It says, I take care of myself. I know that if I am not healthy and sound, I cannot care for another person effectively. These are good reminders. I accept that caregiving involves an incredible range of emotions, from anger to joy, from resentment to compassion. I accept that my feelings are not right or wrong, they just are. And they are as natural and unavoidable as breathing. I ask for and accept help willingly. I involve my family, friends, and the community in the care of my loved one. I understand that it's not my role to do it all, nor is it best for my loved one for me to do it all. I actively seek out information that can help me as a caregiver. I recognize that information is empowering. I respect the preference and decisions of the person I'm caring for. I extend to my loved one the dignity and courtesy I would wish to receive if the tables were turned. I recognize that change, good or bad, is a natural part of caregiving. I remain flexible and open to change. I celebrate the small successes and allow myself to grieve the disappointments. I share my feelings with those who can empathize. And two more. I'm mindful of my own needs and I guard my rights as a caregiver. I do not allow my caregiver's role to overwhelm the other aspects of my life. That's a particularly tough one for sure. And lastly, I forgive myself my shortcomings and I congratulate myself for the effort and love I put into my caregiving. Certainly some much harder than others, easier said than done, but nonetheless, I think a powerful reminder to consider printing out or looking at online. It touches on so many important points in the multifaceted role of being a caregiver. And so from the perspective of just a neurologist, thinking about ways for caregivers to feel empowered, some practical ideas. I think one is remembering that you're human and it takes a village. Just this week, I was seeing a patient and his wife, and she said, I'm not sleeping well. The caregiver said this. And when I explored just a little bit, it was because she's ruminating about how she felt. She yelled at her husband inappropriately and got short-tempered with him. And she was kind of beating herself up for not being as patient as she would have liked to have been with him. And I couldn't make it better, but I did hear her and reminded her, I said, you know, you're human and she's trying to do it all by herself. And connected her to social work, and hopefully that's helpful as a way to get them some help at home. But it really does take a village in terms of providing help, whether it's from other family members or paid help and so forth. I like to remind caregivers that their voice is equally as important in a patient visit, in a medical visit, right? We're often focused on the patient, the person with the diagnosis, asking them how they're doing and doing tests with them, motor tests and so on, but we really encourage the family members, whoever's with them, to speak up and provide their assessment of how things going and tell us how they're doing. So just as a reminder that caregiver's voice is equally as important. And if it's helpful, we try to help give caregivers permission to focus on self-care and not feel guilty. So common to see caregivers saying, well, I'm there all the time. I can't leave him or her alone. So that's just how it goes. And if we suggest, well, what do you do to go to your own doctor's appointments? Like, oh, I've been putting those off, because they feel guilty, you know, sometimes about going and taking care of their own needs. And at least just saying, please, you need to do this. I want to give you permission to take care of your own needs. Sometimes that's helpful to hear, not always, but we offer that when we can. I think encouraging caregivers to stay connected. This, of course, is a self-selecting group. You're here, you're connecting, but there are plenty of people out in the community that are isolated, and trying to encourage them to stay connected, whether it's virtually for virtual caregiver support groups, by phone calls to their family or friends. We try to remind people to stay connected. It's easy to isolate sometimes, particularly in the throes of the pandemic a couple of years ago. I think seeking support groups can be helpful. It's not helpful for everyone. Some people leave support groups and feel worse. Some people feel better. You know, it just depends. It's not one size fits all, but at least trying to help connect people with others who get it, I think, is really critical, because it's easy to feel very alone. Asking the medical team for help is always something to remind caregivers about, because often they don't think to do that. And that's part of what we're there for. We recognize that people living with HD aren't just the person with the diagnosis, but the family. Encouraging caregivers to write down their questions or concerns in advance of a medical visit seems obvious sometimes, but it's easy to forget. I think this is really helpful when you come to a visit to have an itemized list or some key points you want to discuss. And then consider seeking out a palliative care team if you think that would be helpful. A lot of people, again, haven't heard of it or don't know what it means or looks like. And hopefully this has demystified it a bit. So in summary, as I come to the last few slides, how can palliative care help in the face of Huntington's disease? Well, a care team can help strategize with you on how to bring more meaning back into life. Oftentimes that's the spiritual care team. We can provide assistance in medical decision-making, connections to community resources, extra support at home. Symptom management, we try to help with that as well, as I said. And then if we're along the journey, like that extra layer of support cloak idea, and we're meeting with patients and families periodically over years, that long-term relationship, I think, can be another source of stability for people and provide a sense of comfort in that way as well. And then lastly, and not leastly, helping with advanced care planning, documenting wishes, both for patients and their families, is another way we could try to be helpful. So when you zoom out and think about the course of Huntington's disease, when does it make sense to have these kinds of conversations or involve a palliative care team? Well, DX is my abbreviation for diagnosis on the far left. At the time of diagnosis would be a great time to discuss goals of care. And I've discussed with you what goals of care means, to identify a medical decision maker and document it. And then moving forward in time, say point 2 on this timeline, we can provide spiritual support, help with any complex symptom management that isn't already being attended to, help with psychosocial needs, care coordination, connecting all the medical teams if we can. Moving forward again in time, maybe having a family meeting and preparing other family members for some what ifs of the future could be another way. Talking about prognosis. It's not an exact science, but we do the best we can when we're talking about if patients and families want to know how well and how long do I have to live. And talking perhaps about legacy work. Sometimes that can be helpful along this journey. Time point number 4, for example, could be additional family meetings, clarifying or documenting the advance directive, maybe talking about hospice, demystifying that concept, saying, hey, did you know there's a medical team that if and when you get really sick can come to you and provide additional support, medications, et cetera, and really, introduce what hospice is and what it isn't, just as a source of education. And then further along the road, talk about, again, more symptoms, talk about care transitions. Sometimes the idea of whether or not to go into a facility or to bring in extra care at home can be, of course, a really hard or big decision. And talking through that or facilitating a family meeting could be another way that a team can be helpful. And then when someone is in the final stages of HD, the hospice team can be a big source of support. And this, of course, doesn't just apply to Huntington's disease, but when people are at a stage where we think they have 6 months or less to live, they become eligible for hospice care. And hospice is a medical team that comes to wherever the patient is, provides equipment, medications, 24-hour phone access. They become like a new 911. And again, that is anyone is eligible who has an illness where we expect a 6-month or less prognosis. And you should also know that hospice provides bereavement services for their families of patients who have passed away for 13 months afterwards, after they die. So that is a potential long trajectory of years of different time points where palliative care touches, remember it's high touch, not high tech, can be helpful. So my last slide, in summary, as you know now, palliative care is an approach to care and a medical specialty, often team-based, ideally team-based, focusing on quality of life for patients and their families, helping people live as well as possible, as long as possible, in the face of a serious illness at any stage. And spiritual care is often a part of that team, and they can further enhance support in Huntington's and other conditions. Don't forget about the homework, which I suggest would be identifying, if you haven't already, and documenting your medical power of attorney, as well as documenting your wishes. And that's all I have today. I really appreciate your attention.